Well, just to start things off, it looks like we're evolving toward a more uniform procedure to treat patients in terms of combining radiologic and physiologic techniques. And I'd like to ask, a couple of the presenters what they feel would be a reasonable pre-treatment imaging that they would recommend. Anyone want to? Dr. Gitt.
Yeah, I think I'm a big fan of direct imaging of brain targets as opposed to stereotactic methods. I do believe that while continued advances would happen in terms of imaging resolution, some sort of direct imaging of globus pallidus interna should be incorporated. And it's very important to see the interface with internal capsule. There are certain IR-based sequences that do that, but I think FGator probably allows you to do isotropic, millimeter thin images in all three planes. It provides all those advantages of being able to see the GPI as well as the interface with internal capsule. Now, as I was mentioning earlier, I think that's not the only sufficient thing. You should be careful about pyramidal tract because you can get in trouble, especially because what we've seen in our clinical experience that the lesions that are in the posterior part of the GPI are the ones that make the most difference in terms of clinical effect. So then at that point, you're pretty close to the pyramidal tract. What I think needs to happen in future is that we need to improve the resolution of DTI further. Currently, most of the DTI algorithms, give you about 2 or 3 millimeter resolution. So, it's a little bit of a challenge sometimes to superimpose those DTI images onto the FGator or any other types of imaging methods you use. And what I would advocate for folks that don't use FGator type sequences, that at the minimum they should consider superimposing tractography on top of their T2 weighted sequences. So at least that gives them a good target to work with. Typically you'll go 1 or 2 millimeter below the ACPC plane, and if you go by the track location, you can fine tune your target into the posterior pallidum.
Actually, for a related question for Dr. Zarur, you talked about the importance of a careful exam during the procedure. What we don't have is any form of any unified or consistent between centers. So what do you recommend as opposed for an intra procedure examination, knowing that, of course, all of us want the procedure to go as quickly as possible as well? So your comments?
So there is a problem. First, you want to do it faster, but you need to be careful because you need to examine the patient for side effects, especially that you don't have any other monitoring during the procedure. So you need to go fast, probably when raising the temperature till 50 degrees centigrade. Then after that, you need to be very careful with the examination. Although I do the neurological examination very good, I use also the neurologist during the procedure, which my neurologist know the patient. She comes to the MRI and examine also the patient, so it's a team procedure. And this is very important. I think for the GPI, there must be a way to monitor the optic tract by evoked potential or something, and to know where you are, because this is a major obstacle in the GPI.
Again, for our radiological colleagues, there's been good deal of discussion here about intra-procedure and post-procedure techniques to really help us determine the endpoint of the procedure, ensuring durability. So like to throw it out to one of the presenters. What would you recommend? Where are we going toward in terms of procedure that can be done practically during the procedure or shortly afterwards to say, are we at endpoint? Are we going to have a durable lesion?
Well, I think if it's going well, during the clinical treatment, you typically don't need much of imaging, as we've seen. If the patient is improving as expected, most of the times we don't feel the need to do imaging. And one thing to also understand is that even if you do immediate imaging, it may not actually show a big size lesion. It may show something, but that's not predictive of your final lesion size, which typically both DWI volume as well as T2 volume grows over first 24 to 48 hours in our experience. There are patients that don't improve as expected, and in those cases, for a variety of reasons, they may be tired, they may not be responding well, they've received sedation, things like that. So in those cases, certainly it would help to be able to do a good imaging. This morning I heard in the session some folks were doing DWI imaging, and I think that would probably be my go-to sequence to see if you achieved an area of cell death in the desired location, because I have not been impressed with T2-weighted images. I mean, you see something, but I don't think that's necessarily that's going to differentiate between just edema versus truly cell death in the desired location.
Is it okay? I'm a radiologist. I'm involved initially. I'm involved by 3T, and which is a very misery distortion or bad imaging intra procedure. But I'm involved as well I'm using 1.5 Tesla at the same time, and the image is so good, better than the 3D. So I need very beautiful T2 imaging intra procedure quickly as possible by 3T. That's my hope, because we want to know where exactly the lesion is. That is the first thing we have to know to check. So I think still now I'm not satisfied with the 3D imaging during the procedure.
For my opinion, intra-procedure MRI is not necessary, because you have the clinic and you can see the side effect and the temporary effect, and it's time consuming. If you have the effect and you reach 56 degrees centigrade and you have a good effect, so you can do the CT postoperative an hour after and to see what's happened. There is no need for intraoperative. If you didn't reach the temperature, you need to think what to do. What we do a couple of times the same procedure. Like if you reach only 52, we do 4 times 52 and see what's happening. But I don't think intra-procedure MRI can help in the decision.
Okay. Dr. Irsa?
Yeah, I wanted to ask a question. All of us talk about the accuracy, the precision of targeting with focused ultrasound. When we intend to go to a coordinate, the machine is able to focus at that coordinate. But there is another aspect of accuracy that we need to discuss and kind of develop a framework to understand is where is the lesion epicenter in relation to where we wanted to go. What the shape of the lesion is and how the ellipsoid looks and where the center of that is, and how far is it from the intended target. So focus is one aspect, but the lesion epicenter is other. Do the panelists have a recommendation or a framework in mind that we can start using for that?
No takers, okay.
Sijia, do you have any thoughts, Sijia?
Yes.
Well, I think that for easier cases, probably I do agree with you that we don't need intraoperative imaging because we can rely on the clinics, on the neurologists and the neurosurgeons. But let's think at the bad days where when everything could go wrong, will go wrong. And so the SDR that looks good is not going the correct way we are thinking of. The thermal imaging is not perfect. And maybe in that cases, the possibility to see the lesion itself, and so also the center of the lesion, could give us an idea on how the lesion is growing. And so if we need to repeat maybe some sonication to consolidate it before discharging the patient, because of course, once you discharge the patient, everything is gone. You can't do anything more. So probably, yes, we don't need live imaging, a very good live imaging, but in some cases, I would like to see the lesion before discharging the patient, since there are a few techniques that could show the lesion right now.
No, in response to Vibhor's question, I've struggled with the same question all the time, and I think our understanding of what we are ablating is even not perfect at this point, because we are using 2D thermometry for the most part. So, and it suffers from sort of imperfect understanding in all three planes, even though you switch back and forth between axial, coronal, sagittal, plus also volumetric, effects sort of, I think a 3D volumetry might be one of the solutions that will help us understand where the epicenter of the area of ablation is, and some type of algorithm that helps us correct for the movement in target over the course of treatment, so that we can figure out what the entire ablated volume is. I think that would be one essential step towards greater understanding.
I think we're making an argument to get it right the first time, and that's always a very good thing. But the truth of the matter is we're not always getting it right the first time. There was a talk about repeat procedures, and that's the difference between 0 and 1. I really appreciated that. The panel collectively has a lot of experience behind itself in terms of cases, but my question is, are we overly concerned about durability? And when would you consider taking the patient back for repeat, and which way would you expand it?
So who has the most experience in retreatment in the group here?
You hear me? Yes. I think we could ask Daniel Jomono. He has the biggest experience in redo surgeries.
So what are your criteria? Where do you go with respect to the old lesion? How long do you wait before you retreat someone?
It depends on the target, but usually we follow the patient, and if we have clear evidence of a partial target coverage, so we try to include the patient as soon as we can. But we have to give the patient time, because improvements after paleothalamic tractotomy, for example, they don't come all at once, but they come further and further, and they come at least, we have to wait at least 3 months to evaluate if we were successful.
I can say something. Yes. With our 2 cases of retreatment, the obstacle was the reimbursement. Because if there's no reimbursement for the treatment, we cannot do it. And we have enough problem with the first treatment. So with the second treatment, it is also a problem. So that's the main reason why we did it half a year after.
Thank you. Question?
Yeah, thank you. I'm a neurosurgeon. Come here to join the meeting for the first time. So everything is new. I learned a lot. Thank you very much. I'm a neurosurgeon practicing stereotactic surgery for movement disorders for years. So I just wonder if I can ask some question related to radio frequency and DBS. Question number 1, how small, what's the smallest lesion ultrasonic, focused ultrasonic technique can make? Number two, the target VRM GPI has been focused for many years, over 50 years already. So now most surgeons use stimulation, deep brain stimulation to treat the Parkinson's disease. So why do you give me a reason, give me an excuse why you to make lesion in VRM, to treat the Parkinson's disease? We know the VRM is not the optimal target for Parkinson's disease. It's the best for any kind of involuntary movement, but not good for akinesia, something. So give me a reason.
Well, I think I'll take that, and I'll be happy to have support from the rest of the group. But I think you have to go by the data, not by an assumption. And the data says that focused ultrasound can do things with a comparable level of effectiveness. And the question about safety. Yes, it does make an ablative lesion, but it does not have the side effect of brain penetration. And so when you look at both radiofrequency and DBS, one of the things that DBS didn't change is the likelihood of hemorrhage, ischemia, seizure by that physical introduction. This has no path. So again, it's another patient option, and everybody here is looking toward making this more effective,
non-invasive,
safer,
right.
as an option for patients.
Very good.
When you have a patient that comes to you with a tremor, Parkinson or essential tremor, and you give him these two options, even sometimes he has bilateral tremor, and you give him the two options, he will, most of the time, will say, no, you will not do a bear hole in my head and put hardware and change battery. I want focus ultrasound. And it's happened every day. You think that for bilateral tremor that he has and all the other problems, DBS will be better for him, and he will say, no, I want only one hand, I can use it, I will write with it, I will drink with it, that's what I want. And you see it more and more in the clinical practice. And about the first question about how big is the lesion, it depends where you see the lesion, when you measure the lesion. If you measure it immediately, it seems like a bigger. But there are patients after a year with no tremor, and you do the MRI, and you hardly see the lesion, So the real lesion that focus ultrasound is doing is the tiny one. That's why I'm saying it's like a pen in your hand. Don't think that the lesion that you saw a day or a week after the procedure, this is the lesion. No, this is the edema, this is other thing that happen around the lesion. Look after a year and you will see that it's pinpoint even in the success patient.
Thank you. And I think we'll take the last question. Yes,
Thank you very much.
To make one more comment in response to why target the thalamus for Parkinson's disease. And specifically, I see the best potential with young onset, people that are tremor dominant, and they're a vocational age, and the tremor is of a nature that it's interfering with their ability to stay employed. And by doing an initial early treatment with focused ultrasound, you're not precluding any future bilateral treatments. So I think it buys time it could potentially buy time for people along the way and along the course of their disease.
Thank you. I think there's good documentation that tremor predominant Parkinson's disease is a really different entity from the other subtypes. So
I wanted to extend slightly on what Dr. Galley said before about the side effects, as you asked. The two dimensions that are feared, the one of cognition and dysarthria, right? These are two main elements. In terms of cognition, patients that have preoperatively reduction of their Montreal cognitive assessment may present some pejoration after because they are at the limit of the indication. In spite of that, and we have one patient over 10 who are at or below the normality in the Montreal cognitive assessment, the whole group does not present reduction of the cognitive function. We had one patient who had a reduction of 2 points after surgery, and she had a vascular anomaly very close to the mammillothalamic tract, and we saw an extension that we stopped as we could of the thermal application toward this area. She had 2 points loss on the Montreal cognitive assessment at 2 days after, but at 1 year after, she was improved as compared to the preoperative state. This is important, what Dr. Calais said, time is a very important factor, and we see indeed improvement along more than a year. Dysarthria, if patients have got no problem with dysarthria or dysphonia before, we don't create dysarthria surgically. Again here, patients that have a clear-cut reduction of their voice with dysarthria and dysphonia may have some losses that can also recover. But a creation of dysarthria does not happen, and we haven't had a single capsular effect over the 150 cases. And I think what Dr. Gallet mentioned about the way we can exactly localize the thermal application and the precision we've published at in the value of 0.5 millimeter explain this possibility.
Thank you, I appreciate it. And I'd like to thank all the speakers for their fine presentation and their participation this morning.